And here is your question. Right. So if you have read and understood, considering it surgical pathology station, kindly tell me what are the differential diagnoses for this patient that you'll consider?
For this patient, I would like to consider my first differential would be malignant melanoma.
Okay.
I would also like to consider dysplastic nevus or xeroderma pigmentosum. I would also like to keep squamous cell carcinoma as my differential.
Can you name any infectious condition which infects lower limbs lymphatics and can mimic the same condition as this one?
It could be a cellulitis of the lower limb.
Yes, very good. Can you tell me what are the different types of malignant melanoma?
Yeah, we have the lentigo maligna, superficial spreading.
How would you classify
dermoplastic,
them? Like depending upon the location,
depending
shape,
on their
and
location,
yes.
shape, and yeah, whether they grow inward, outward, or downward
Yes.
into the dermis. So based on that, we have the lentigo maligna, superficial spreading,
That
dermoplastic,
faces.
acral,
Okay.
and nodular melanoma.
Yes. Okay. Can you describe nodular melanoma?
Yeah, they appear as a lumpy, and then they are often blue-black in color. They may grow faster and spread downwards.
Can you describe or what do you understand by the term epithelioid melanoma?
Epithelioid melanomas are the melanomas which contains epithelioid cells, ma'am, which are large giant cells which are round with abundant eosinophilic cytoplasm, which has prominent nuclei and large nuclei, ma'am, which are mostly common in nodular and superficial spreading melanomas.
Good. Okay, considering this patient, where would you suspect primary lesion to be?
Yeah, primary lesion is in the leg, ma'am, right? Most probably in the toes.
Nail beds or yes.
Nail beds,
okay,
yeah.
And it has metastasized to? What are the possible locations where it can metastasize to?
It can metastasize to the inguinal lymph nodes, ma'am.
And more? It can even to abdomen and from abdomen, yes, to the chest and brain as well. So,
yes.
Right, you have to tell the whole course. Can
yes.
you please tell me what is the treatment alternatives that can be offered to this patient? Treatment alternatives, yes.
Yes. Considering this, I can go for. I need to first stage this, ma'am. I need to do excision, excision biopsy with safety margin.
Yes.
And then also may offer him block inguinal lymph node dissection.
Yes.
And also radiotherapy, ma'am.
Okay, that can be offered. Right. Can you please tell me? Can you please tell me what are the genes which are responsible for familial malignant melanoma?
Yeah, we have the CDKN2A and CDK4, BRCA2, and also MCA1R.
Can you please tell me how would you, what are the margins that you'll keep in your mind once you are excising the malignant melanoma?
We have the Breslow thickness
Yes.
and also the Clark's level.
Yes.
Mainly for the excision, we go for the Breslow thickness, where we excise the safety margin according to the thickness of the, depth of the invasion, whereby there are 4 levels. If it's 0 to 1 mm thickness, then we go for 1 centimeter excision margin. If it is 1 to 2 mm, we go for 2 centimeter, 2 to 4, 3, and then if it is more than 4, 3 centimeter.
When considering Breslow thickness and Clark's level, which one is more reliable?
For excision, I think Breslow is more reliable.
Good. Okay, can you please tell me if it's possible to take a sample intraoperatively? If yes, then what type?
Yes, we can go for the frozen section, the most surgery micrographical oriented.
Okay, can you mention few poor prognostic factors when it comes to malignant melanoma?
Yeah, we have the old age, male gender. We have the increased thickness, increased tumor thickness, that's the Breslow thickness, increased depth of invasion. Then it could be invasion of the lymphatics, perineural invasion, regional or distant metastasis, and also the type of melanoma, usually nodular and amelanotic. They are poor prognostic factors.
Can you mention few skin conditions which are associated with melanoma?
Yes, ma'am. We have the xeroderma pigmentosum, albinism, Fitzpatrick skin type 1. Then we have the dysplastic nevi, multiple nevi, and giant congenital pigmented nevers.
Okay, right. Can you tell me if you have to differentiate between melanoma and the skin cancer, how would you differentiate, or what are the factors that you look out for?
Yeah, melanoma, they usually can occur anywhere, but it's common in sun-exposed area. But other skin cancers, it is usually common in sun-exposed areas. Melanoma can occur from the lower layer of epidermis, but in case of squamous cell, it usually arises from upper and middle layers. Melanoma occurs common in young age, squamous cell in old age, and the appearance will be in melanoma. It appears as a multicolored irregular border mole, and in squamous cell as a red bump, which may be ulcerated, and malignant melanoma has poor prognosis and spreads faster.
Yes.
Yeah, and it needs, the treatment option can be surgical, radio, and chemotherapy. Malignant melanoma, squamous cell, usually surgical.
All right. If you have operated on you've done excision on a patient, excise the malignant melanoma, what things you have to keep in your mind to make sure you have taken out adequate amount of the margins?
Depth of invasion, ma'am. The Breslow thickness.
Yes, you have to do the re-excision. Yes, keeping that in mind. There is like frozen section or MRCS microscopic surgery. Okay. When a patient presents with malignant melanoma, it also poses another risk factor, which is very much common. Can you tell me which?
Yeah, they are more. They produce a hypercoagulable state whereby they are more susceptible for the venous thrombosis,
yes,
which can lead to pulmonary embolism.
Yes.
Like this patient, most probably, I think this patient is having pulmonary embolism, whereby he presented with difficulty in breathing.
Yes, very good. That was the last question, right? Otherwise, if you can tell me one, if you have to differentiate between malignant melanoma lesion, so what are the macroscopic features and what are the microscopic features that you go for?
Yeah, macroscopic features, usually they are asymmetrical lesion and of different size. They have irregular border. They have different color color variation, and yeah, they have elevated surface. In microscopic,
yes,
they have,
describe the image, please?
yeah, this is a raised lesion with irregular border, hyperpigmented,
Yes.
and it has also surrounding slight mildly hyperpigmented lesion, surrounding lesions,
Yes.
which could be satellite lesions.
Good. Thank you. Start with your timer and here is your question. Yes. So if you have read and understood, considering its surgical and optimization, kindly please tell me what are you looking at?
This is the image showing the cranial fossas along with its foramina.
All right. Can you tell me how the cranial fosses are divided? How many of them are there? And yes,
there are three cranial
good.
fossas: the
Yes.
anterior cranial fossa, then the two middle cranial fossas, and the
on
one
either
posterior.
side. Yes, very
yes,
good.
and the posterior cranial fossa.
Can you please tell me how this division is done, or what are the demarcations which divides these cranial fosses?
Yes, and the anterior cranial fossa and the middle cranial fossa are divided by the lesser venous sphenoid bone.
Okay.
And the posterior cranial fossa and the middle cranial fossa are
Would you be
divided
able
by
to identify on this image which number would be representing the division between anterior and middle cranial fossa?
Yes. Ma'am, number 32 or 42 and
42,
number
yes.
44.
Okay, good. That is located. Okay, yes, please. Right, yeah. Okay. That was the between, okay, the middle cranial fossa. All right, yes, please. Continue.
Yes, ma'am. And between the middle cranial fossa and the posterior cranial fossa, it is the petrous part of temporal bone, which is the number 44 or 37.
Okay, and if you can tell me the boundary of the posterior cranial fossa, please.
Yes.
What is anterior, posterior, and laterally, and then superiorly, and then inferiorly?
Yes, ma'am. So the posterior cranial fossa, the anterior border is formed by the clevus and the petrous part of the temporal bone.
Yes.
The lateral border is formed by the squamous and the mastoid part of the temporal bone.
Good.
And the posterior part is formed by the occipital bone. The roof is formed by the tectorium cerebri, and the floor is formed by the foramen magnum.
Right. Can you please tell me what are the structures which pass through the foramen magnum, and which number is foramen magnum? If you can identify, please.
The number 11 in the image is foramen magnum.
Good.
The structures passing through the foramen magnum, there are two arteries, that are the anterior and posterior spinal arteries and the vertebral artery.
Yes.
Then there is the lower part of the medulla oblongata and the spinal root of accessory nerve, and the tentorial membranes and the apical ligament of tens.
Good. Okay. Can you please identify jugular foramen? Which number is?
It is the jugular foramen number 30 on the left side, ma'am.
Okay, it's part of posterior cranial fossa or middle cranial fossa.
Posterior cranial fossa.
Very good. So what are the structures which pass through the jugular foramen, please?
Yes, ma'am. So the internal jugular vein, the inferior petrosal sinus, and the 9th, 10th, and 11th cranial nerves pass through the jugular foramen.
Yes, good. Can you please tell me what is clevis?
Yes, ma'am.
And
Clevis
which number is clevis, if you can identify?
Yes, ma'am. So clevis is number 4.
Very good. Yes. Significance. What is the importance of it?
The internal carotid artery lies lateral to the clevis, as well as the abducen nerve is also lateral to the clevis, and
Okay.
it forms the anterior border of the posterior fossa.
Good. Okay. Can you please now tell me the boundaries of the middle cranial fossa?
Yes, ma'am. So the middle cranial fossa is the anterior border of the middle cranial fossa is the lesser wing of sphenoid bone. The posterior border is the petrous part of temporal bone. The lateral border is formed by the squamous part of the temporal bone.
Would you be able to identify trigeminal impression for the trigeminal ganglia?
Yes, ma'am. It is on the petrous part of the temporal bone. It is
Yes.
number 44 on the image.
Good. Okay. Can you please tell me what's the significance of it?
And the trigeminal ganglia lies over it.
There, yes. Okay.
Yes, ma'am.
Can you please tell me the attachments on the styloid process? It cannot be seen
Yes,
here,
ma'am.
but then
So, yes, ma'am. The styloid process gives attachment to the stylohyoid muscle and the stylohyoid ligament,
yes,
the styloglossus muscle, and the stylopharyngeus. Ma'am.
these muscles are muscles of what? Which organ?
Pharynx and larynx, and the
Tongue.
tongue. Sorry,
Yes.
glossus.
So what is the nerve supply of the tongue?
And the nerve has two portions for the nerve supply. The posterior part is supplied by the glossopharyngeal nerve, the general as well as the taste, and the anterior part for the general it is lingual, and for taste it is chordative.
Okay, if a patient presents with the lytic lesions on the skull, what might be the cause? Can you name few causes?
Yes, ma'am. So it could be skeletal metastasis from malignancies such as renal cancer or breast cancer. Then it could be osteomyelitis, Paget's disease, sarcoidosis, and multiple myeloma.
Okay, good. Can you name the muscles which retract the tongue?
Yes, ma'am. Styloglossus and hyoglossus.
Very good. And these muscles are supplied by which nerve?
Glossopharyngeal nerve.
Are you sure?
Hypoglossal nerve.
Okay. Can you please tell me what are the structures? Yes, what are the structures which pass through the foramen ovale?
Yes, ma'am. So the structures passing through the foramen ovale mandibular branch of the trigeminal nerve, accessory meningeal artery, lesser petrosal nerve, and the emissary veins for the
Can you
intervertebral.
identify which number is foramen ovale?
Yes, ma'am. So it is number 12 on the right side of the.
Yes. Okay, good. Which, what is this part called?
That is the
Yes. In anterior cranial fossa, what is this part called?
cribriform fossa.
Yes.
Yes,
What's
plate,
the
cribriform
importance?
plate.
Yes. What's the importance of this cribriform plate?
Various nerves and I don't know. I'll come back.
Which? Okay. That was the last question. Maybe someone can
Yes,
help you. Dr. Karma, Dr. Snehal, maybe you can.
Ma'am, all the nerve roots of olfactory nerve pass through
Yes.
the cribriform plate,
Yes.
and
And?
it is very prone for fractures after trauma because it's a
Yes.
weak and CSF
Yes.
weak.
Yes. Good. Very good.
Thank you, ma'am.
Nice. She still remembers it. Good. Thanks. Here is your question. Right. So if you have read and understood, considering the clinical examination of this patient, kindly begin.
Okay, first I will enter the room and wash my hands.
Yes.
Then I will introduce myself to the patient. Hello, I'm Dr. Shrudeep, one of the examiners here. Could I
Yes.
please take your name and age, please?
I'm Smith, 56 years old. Continue, please.
Okay, nice to meet you, Mr. Smith. Today I've been asked to examine your tummy, which will involve looking at you, feeling your tummy, and also telling you to perform some instructions. Will that be okay for you?
Yes.
Okay, thank you. Now we'll have a look at your tummy. I'll look for any abdominal distension or jaundice, swelling, or any skin changes.
Can you please,
Then,
before that, tell us the exposure and the position of the patient, please?
okay, could you please lie down on the couch, and I want a chaperone, please. Could you please open your gown? Usually in this patient, this patient is already lied down. So
Lie down, yes. But the exposure you'll do. So would you definitely need a chaperone for this case?
Yeah, I need a chaperone for this class, and I will tell the patient to put off the gown.
Okay, then?
Then I will have a look from the eye level, also from the end of the bed at eye level, and I will look for any abdominal distension, any skin changes, swelling, and then I will ask, okay, do you have any pain in your tummy?
Yes.
Okay, I'm sorry, I'll be gentle. Do you need any painkillers right now?
No, that's okay.
Okay, then I'll start palpating the tummy, and when there will be severe pain, then I will tell that the further abdominal examination can't be done due to the severe abdominal pain, and I will have to assess the patient according to the CRISP protocol. So as the patient is talking, so air is patent, I'll move to the breathing. In inspection, I'll look for any central cyanosis or chest movements, and in palpation, I'll check the position of the trachea, and also check the chest expansion at the level of the nipple, and telling the patient to take some deep breaths. And also I'll percuss and auscultate the chest anterolaterally and anteriorly from the first intercostal space to the sixth, and also above the clavicle, and also laterally the fourth up to the fourth intercostal space. And then I'll move to the circulation. In circulation, I'll check the pulse and blood pressure and capillary refill time, temperature, and also edema, dehydration, or anemia. Then I'll move to the disability as the patient is talking, so he's alert. And then in exposure, I'll expose the dressing and check the wound if it's healthy, or if there is any discharge or not. And I'll also, if there is any tears, then I will tell the patient to put it off, and I will press for the cuff and look at the patient and look for any cuff tenderness. And then I'll tell that I need a news chart, and then I'll thank the patient and tell the patient to redress and present my case.
Yes, but you had still time. 2 minutes and 20 seconds.
Okay,
So-
I want to look at the news chart.
Yes. So you'll be given the file, patient's file, patient charts, FBC, ECG.
Yeah. And in the news chart, I look for the pulse rate, oxygen saturation, temperature, respiratory rate, and also if there is any leukocytosis or not. And in the ECG, I look for any atrial fibrillation.
Okay. Considering this case, what are the things that you will not do if you have to compare this crisp case with the pulmonary embolism crisp case? So what are the things you'll not do?
I'll not examine the patient from the back because
Okay, very
patient
good.
can't sit. Yeah.
Yes, and you'll not be taking the pulse and the blood pressure because it will be provided.
Yeah,
The
it will be
patient
provided in the
chart.
chart. Yeah.
Yes. All right. Okay. Because you still have time, so I want you to avail this time and tell me if there is anything that you have missed. Did you auscultated the heart?
No, yeah, I have to look for the auscultate the heart sound and check the JVP. Also.
Yes, neck veins, right. So considering the auscultation of the heart, for this scenario, which areas would you auscultate? If you can quickly tell me.
I'll auscultate in the mitral area, pulmonary area, aortic and tricuspid area to look for any abdominal heart sound, or if the heart sound is, if there is any murmurs.
What is the significance of looking at the ECG of this patient? What would you be looking in the ECG?
In the ECG, I'll look for any features of atrial fibrillation or
Very good.
pulmonary embolism.
And in the full blood count, what would you be looking at?
I'll be looking at leukocytosis.
Good. So white blood cell count would be high.
Yeah.
Okay. Now you can start. 9 seconds are left. You can start presenting your case.
Okay,
Please.
Mr. Smith, 56-year-old male, presented with shortness of breath, abdominal pain, which radiates to his left shoulder tip, and it's his sixth POD of sixth postoperative day of left hemicolectomy. On abdominal examination, there was a dressing. There was a midline scar covered with dressing, and no other skin changes were detected. And on palpation, there was severe pain, and further examination couldn't be done. On the airway examination, the airway was patterned, and on breathing examination, there was no central cyanosis, and the chest movement was normal. On palpation, there was on palpation, the chest expansion was also normal, and on percussion, the note was resonant, and on auscultation, there was no head sound, and the respiratory sound was normal.
Okay.
And in assessment of the circulation, there was increased respiratory rate, and also decreased oxygen saturation, and increased temperature. And on exposure, the wound was healthy, and there was no discharge, and the patient was alert, and there was no cuff tenderness.
What are your provisional diagnosis for this patient?
So
or
my
differential
provisional
diagnosis? Or different
provisional diagnosis will be anastomotic leak
yes.
followed by hemicolectomy.
Okay.
Following hemicolectomy.
Yes. What else could that be?
Why
do you think it's causing abdominal pain? Or why the pain is referred to the tip of the shoulder?
Because in anastomotic leak, the gut contents are irritating the peritoneum, so it's causing abdominal pain, and it's also irritating the diaphragm, so the pain is referred to the shoulder.
Can you now tell me how do you plan to manage this patient? What should be the plan of management? Yes.
Yeah, I'll first put the patient in a nothing per oral, and also administer IV fluid and antibiotics, and I will give NG tube and catheterization, and if there's any central venous line is needed, I will refer him to HDU, and also also order some investigations like arterial blood gas, urea and electrolyte, and chest X-ray, CTPA, abdominal ultrasound, or CT scan with gastrography in enema. And if any, then I will plan for surgery. He may need a laparotomy and Hartmann procedure with good peritoneal tolerating and adequate drainage.
Very good. Okay, management you know very well, but my issue is that you went through the examination very quickly. Maybe that's the issue. You go too quickly, so the impression that it gives you that you haven't done it completely, or you probably haven't understood. So there's no need to be in a hurry. 6 minutes are yours. You have to avail them peacefully.
Okay, ma'am. I am usually worried about the time management.
Yes.
If the 6 minutes are over or not. So yeah.
True, that's what. But then you have to go slow, like not too slow, but like you have to consume your time, and that you can do with practice. Okay, started your time now. And where is your question? Right. So if you have read and understood, considering a surgical pathology station, kindly tell me what are the differential diagnoses that you'll consider for this patient?
This patient has ulcerative colitis. It might be inflammatory bowel disease and diverticulitis and FAP,
What is that?
colorectal CA.
Okay. Can you please tell me what is ulcerative colitis?
Well, ulcerative colitis, irritable bowel, inflammatory bowel disease, which is affecting the rectum and the colon in the form of the colitis, having a characteristics ulcer over the rectum and colon.
Can you tell me what kind of condition that is? How is it transmitted? Or yes.
It's immune idiopathic basically.
Okay. It's not quite idiopathic. Can you tell me what are the genes which are involved in the position of this condition?
It involves oncogene mutation in the oncogene as well as the tumor suppressant genes. And it causes the it started as a loss in the APC gene, which causes the hyperplasia, then mutation in KRAS, which causes dysplasia, and then loss in P53, which lead to the adenocarcinoma. And it's an autosomal dominant.
Yes, now you are telling me.
Yes, ma'am.
So can you please tell me the role of P53 gene in this one and APC gene?
P53 basically it's a tumor suppressor gene. It detect any mutation and on the cause.
They inhibit proliferation.
Yes, ma'am.
Okay, can you please tell me what is the pathophysiology which lies behind it, behind this condition? Now, pathophysiology is idiopathic, okay? So what is the etiology behind it?
Etiology of P53?
No, ulcerative colitis we are talking about.
In ulcerative colitis, sorry, ma'am. Can we
Okay.
come back to
Yes.
this question later?
Later. Okay. All right. This question later. Okay. All right. This patient at the age of 22 was sent for surveillance colonoscopy. Kindly tell me, what is the schedule for surveillance colonoscopy according to the NICE guidelines for a patient, for an individual who is suspected of having ulcerative colitis?
Yes, we will do colonoscopy after 5 years initially.
Okay.
And if the patient has the symptom, we will do per year.
Every year.
Yes.
Okay. Right. And what is the management that can be offered?
Well,
the
it
patient?
depends. Yes, well, it depends in the condition of the patient. If the patient does not have any symptoms, then we will give only the conservative treatment, in which we will give some dietary control, and otherwise we will go for the medical treatment, in which we advise immunosuppressants and mesalazine, which is a 5-amino salicylic acid. And if it's refractory, then we can advise steroids as well.
If you are doing the colonoscopy in the patient and you have to confirm that it's ulcerative colitis, what are the features that you'll be looking for, both macroscopic and microscopic?
In macroscopic, we have extensive ulceration, which is superficial, with the contact bleeding, and they have formed the pseudopolyps. In microscope, we see the crypt abscesses all over the rectum and the colon, and it's a continuous inflammation, ulceration. And
yes.
yes.
Okay.
And
can you define the term ulcer?
Ulcer is a discontinuity of the mucous membrane or the cell membrane due to the dislodgement of the necrotic foci.
What are the lifestyle changes that you can advise to this patient in order to prevent the risk of C. colon?
In the ulcerative colitis, we ask patient to stop smoking, and we will give some alcohol restrictions and lifestyle modification, like regular exercise and increased dietary fiber intake in diet.
And low fat intake?
Low fat, yes, ma'am.
Okay, can you please tell me what are the most common types of carcinoma of colon?
We have adenocarcinoma.
And is it the most common one? Okay, can you tell me how would you classify the colon carcinoma?
Colon carcinoma is classified by Duke's criteria as well as TNM staging.
Yes.
Yes.
Please tell me both of them.
Duke criteria is divided into A, B, C, D, E. In A, the tumor is just into the till the mucosa. In B, it's intramuscularis propria. In the C, it's involving the till the adventitia. And lymph nodes are involved in, like C1 and C2, then less than 3 and more than 3 lymph nodes. Okay. And in D, the metastasis is present.
All right. Can you mention few extracolonic manifestations of ulcerative colitis?
Yes. In the ulcerative colitis, we have a primary biliary cirrhosis, clubbing, and then pyoderma gangrenosum, iritis, conjunctivitis, and sclerosing cholangitis, and erythema nodosum, and gallstones, and as well as renal stones.
Okay. Right. Can you please tell me what is the surgical management that you can offer to the patient with
yes.
colitis?
In ulcerative colitis, well, it depends on the condition. If the patient comes in the emergency ER, we will definitely go with the end colostomy with Hartmann procedure. And if the patient is stable and we plan the surgery, then in elective cases we will go for the primary resection anastomosis.
Okay. Can you please tell me the role of proto-oncogene and tumor suppressor genes?
Sorry, ma'am, can you repeat your question?
The role of proto-oncogenes and tumor suppressor genes. Or
Yes, ma'am.
you can tell me the types of adenomas.
Ma'am, proto-oncogenes, basically these are the normal genes which inhibit, which regulate the cell growth and cell proliferation. When there is a mutation, it become the oncogenes, which produces the proteins which increase the cell growth in the absence of any growth promoting signals. So the cell start dividing and proliferating without any stimulus. So it increases the convert into the carcinoma.
Okay, good, thank you.
Thank you, ma'am.
Can you explain the lesion you are looking at, please?
It's a colonoscopic view of the colon,
Yes.
seeing the superficial ulceration.
Okay, and you have to explain the lesion. Is it like you said superficial, and is it continuous?
Yes, it's a continuous superficial.
Yes. So you have to convince me by explaining the lesion that you're
And
looking at ulcerative colitis.
Yes, and it's
Crohn's
a bleed.
lesion.
Yes, ma'am. It seems like it's a continuous, and the contact bleeding is also there.
Yes. Okay. So there could be some ulceration.
And we can see the polyps, small polyps.
Okay. All right, good. Thank you. And here is your question. Right. So if you have read and understood considering a surgical and optimization, kindly tell me, what are you looking at? Both
Yes,
the
ma'am.
right hand side and the left hand side.
Yes, ma'am, it's a vertebral body, most probably the lumbar vertebra.
Which one are you talking about? The first, the left hand side one, or the right hand
Yes.
side one?
Right hand side one, ma'am. Left hand
All
side
right.
will be
Okay.
cervical.
Right hand
Yes, ma'am.
side one is from the lumbar region, you're saying, right?
Yes, ma'am.
So what are the characteristics of a vertebrae which tells you that it belongs to lumbar region?
Yes, ma'am. The body of the vertebra is kidney shaped. The vertebral canal is triangular. It's heavy.
Yes.
The spinous process is quadrangular hatchet shaped, and
Okay.
it has a mammillary process. There is absence of costal costal cartilage as well.
Absence, okay.
Absence of costal facet on the body.
Yes. Okay.
And on the transverse process, there is no foramen transversorial.
And what else is there? These are long and they are slender.
Yes,
And there is what? Yes, excessive process on posterior surface of base of each process. So is it as it is explained? What about the articular process?
Yes, ma'am. The articular processes are superior and inferior, and they are the superior are directed posterolaterally, and inferior ones are anteromedially.
Kindly discuss the spinous process of the lumbar vertebrae.
Yes, ma'am. It's a
How would you
quadrangular
yes.
or hatchet shaped,
Yes.
and on the
and short.
it's yes, short
sturdy.
and stout.
Yes. Okay, good. Right. How many lumbar vertebrae are there?
There are 5 lumbar vertebrae.
Okay. And how many spinal nerves are there? Lumbar region. How are they coming out?
Yes, there are 5 lumbar spinal nerves.
Okay. Now, if we can move to the image on the left-hand side, this vertebrae belongs to which region, please?
Yes, it also has, ma'am, posterolateral process. So it is also a lumbar vertebra.
Very good. And
Most
what about the body?
Yeah, it's flattened and it's not very heavy. So
okay. So approximately which in the order 1, 2, 3, 4, 5, which lumbar vertebrae could that be? Is there any different?
Yes, ma'am. Most probably it's the first lumbar vertebra.
Okay. Why?
Because sorry, ma'am, I'm not sure about this actually.
Okay, feel free to guess.
Yes, because as the weight bearing goes from increases from first to the fifth lumbar vertebra, so the body of the vertebra
thickens.
Yes, ma'am.
Yes. Good. It was very good. All right. Can you tell me, in between 2 lumbar vertebrae, there is something. What does it hold and what's the purpose of that?
Yes, there are in between 2 lumbar vertebrae, there is intervertebral foramina, and it permits the passage of various structures such as roots of the spinal nerves, the dorsal root ganglion, vertebral arteries, the segment from the segmental arteries, and the plexus connecting internal and external paravertebral plexuses, and also certain recurrent meningeal nerves.
Yes. And transforminal ligaments. Okay, can you please tell me about the intervertebral disc?
Yes, ma'am. Yes, ma'am. It consists of 2 structures: the nucleus pulposus and annulus fibrosus. It is made up of type 1 or type 2 collagen, and it forms the cartilaginous joints between the vertebrae.
Yes.
There are certain changes in this intervertebral discs as the age advances, and there are various pathologies associated with it due to protrusion of the nucleus pulposus.
Okay, what type of joint is this?
This is secondary secondary cartilaginous joint, ma'am.
Okay, good. Can you please tell me, if you have to do the lumbar puncture on a patient, from outside to inside, what are the layers that you'll come across? And at what level would you be doing it in an adult?
Yes, ma'am. In adult, I would like to do the lumbar puncture is usually done at the junction of L4 and L5 disc.
Yes.
It is at the supracrestal level, which is the highest point on the iliac crest.
Yes.
And during this procedure, we traverse skin, subcutaneous fascia, then supraspinous ligament, interspinous ligament, ligament flavum, dura mater, arachnoid matter, and then subarachnoid space.
Arachnoid. Okay. All right. Good. Can you please tell me at what level spinal cord ends in the newborn?
It ends at L3, lower level of
Level,
L3 body.
okay. Can you tell me the contents of the spinal canal below the level of L2?
Yes, ma'am. In adults, it contains the filum terminae, nerve roots from the spinal nerves, then the dura mater, arachnoid mater, and cauda equina.
Yes. Can you tell me, okay, you told me just now. Can you please tell me what are you looking at now? Which type of vertebrae are you looking at? If you can discuss picture A first, please.
Yes, ma'am. It's the cervical vertebra.
Okay. Can you
Typical.
identify the structures labeled A, B, C, and D in picture A, please?
Yes, ma'am. It's the superior cervical, superior articular facet.
Yes.
B is the lamina, C is vertebral foramen,
Yes.
and D is the pedicle.
Okay. All right. Can you now discuss?
D is the pedicle.
Yes, D is the. Can you discuss the picture B, please?
Yes, ma'am. B is the spinous process. A is the transverse process, and B is the
Yes, inferior.
Sorry, ma'am, I forgot. Yes, ma'am.
Try to look. It's some kind of.
It's the facet, ma'am. Articular facet on the. It must be the thoracic vertebra. Yes, ma'am.
Are you sure? Okay. If we are moving on to picture C.
Yes, ma'am. It's the typical cervical vertebra with foramen transfer. It's C3 to C6 maybe, ma'am. Bifid spine and triangular. The triangular vertebral foramen.
What are the differences between the cervical spine, the cervical vertebrae, and the thoracic vertebrae? How would you tell? How would you know that these are the vertebrae of the cervical region?
Yes, ma'am. Typical cervical vertebra, it has a light kidney-shaped body. It has a bifid spine. The vertebral foramina is triangular, and in the transverse process, there is foramen transversarium. In the typical thoracic vertebra, the body is heart-shaped. Vertebral foramen is round. The spine of the thoracic vertebra is directed downwards and backwards, and it has a costal facet on the body, and also the transverse process. Transverse process of the
through A.
Yes, ma'am. It's a foramen transversorium, which there is vertebral artery and a vein and cervical sympathetic chain.
Okay. Can you please tell me what are the ligaments which are attached to odontoid process?
Yes, ma'am. There is apical ligament of Dens, alar ligament, and transverse ligaments.
What type of joint is atlantoaxial joint?
It's the synovial pivot type of a joint.
All right. Can you name few ligaments which are attached between C1 and C2?
Yes, ma'am. There are anterior and posterior atlantoaxial joints and the transverse ligament.
Okay. Can you please tell me why one cannot feel the upper spinous processes?
Yes, ma'am. They are. Yes, ma'am. They are short. They are bifid and covered or attached to the nuchal ligament.
Very good. Where would you feel the first spinous process?
It's at the C7 level, which is long and non-bifid.
Yes, very good. Okay, comparing C1 and C2. So what are the differences or what are the characteristics of C1 and C2? And what are they called? They both of these have special names. They are called atypical cervical vertebrae.
Yes, ma'am. First is the atlas vertebra. It has rudimentary body.
Yes.
And there is a small anterior and posterior arches with foramen transversarium.
Yes.
It also has a facet for on the anterior arch to join to form a joint at the peg or odontoid process of the second. The second is called as atlas. In this, the body is converted into a superior process, which is called as odontoid process, which articulates with.
Okay, last question. There are 7 cervical vertebrae, but then how many spinal nerves which emerges from them?
Yes, ma'am. There are 7 cervical vertebrae and 8 cervical nerves.
Yes.
So the first nerve passes above the atlas.
Okay, and the last one?
And
P8?
Yes, ma'am. Last one passes below C7.
Very good. Very good. Excellent. Starting timer, and here is your question. Right, so if you have read and understood considering the history taking station, kindly
Yes, ma'am.
begin.
Hello, I'm Dr. Beanish, one of the surgical doctor. May I confirm your name and date of birth, please?
I'm Tom, 50 years, 36 years. I'm Elise, 36 years old.
Okay. Hello, Tom. Nice to meet you. How may I
Alice.
help you today? Alice. Okay.
I'm Elise.
Alice. Okay.
Yeah,
Hello,
doctor.
Alice. Nice to help you.
Yeah, I've been having this difficulty in breathing, like it's like suffocating, and then, I don't feel comfortable.
Okay. I'm so sorry to hear that. Now I'm going to ask you a few questions about your problem. Are you okay with this?
Yeah, okay, doctor.
All right. Can you please tell me when did you first notice this problem?
It's been few months, yeah.
Okay. And can you tell me does this problem started suddenly or gradually?
It started gradually, doctor.
Okay, all right. And can you tell me that is it present all the day or it's like comes and goes?
No, it's not there always. Like it comes and goes.
Okay. Okay. And is there anything that makes this problem worse or increased?
Yeah, whenever I'm like, stressed out, like I think about something too much, then,
Okay,
I
all right.
feel that I have this discomfort in my chest. Something is pressing on it.
Okay, I'm so sorry to hear that. And is there anything that makes this problem relieved or decreases?
Yeah, when I try to, calm down, sit down, and, that
Okay,
time
all
it
right.
helps me.
Okay, that's good to hear that. Now, can you tell me that do you have any chest pain that radiates to the back?
I don't have pain as such, but there is this discomfort, chest discomfort.
All right. Okay, I'm so sorry to hear that. Do you have any cough or
No, I didn't.
no cough? All right. Okay. And have you noticed? Okay, so you don't have any cough. Do you have any painful swollen legs?
No,
All right. Can you tell me that? Have you had any recent surgery?
no.
All right. And tell me that have you been recently ill or had fever?
No, I don't remember.
Okay. Do you find that you are having some wheezy sounds in your breathing?
No.
All right. What about your appetite? How has your appetite been?
It's okay. It's fine.
All right. And have you noticed that you're having some unintentional weight loss?
No, I haven't noticed that.
All right. Okay. And can you tell me that, are you aware of your heartbeats?
Yeah, doctor. Yes, sometimes like usually
Okay.
when I am, having this discomfort, then I feel that my
Okay.
heart is beating so fast.
Okay. All right. I'm so sorry to hear that. How many pillows do you use in the nighttime to get into sleep?
I usually am comfortable with one.
Okay. And have you ever wake up for gasping for air?
No.
Okay. And do you have any this shortness of breath when you lie flat on the bed or on the floor?
No. I just
Okay. All
have
right.
that when I'm, when I have that
Okay.
thing,
So,
like, then I feel like maybe I'm short of breath,
all right. Okay. And do you have any other medical condition for which you consult your GP or any other problem?
No,
All right. And is there in your family who has had the similar issues that is related to anxiety?
no.
Okay. Do you take any medications?
No, not really.
Okay. Do you have any drug allergy?
No.
All right. Now I'm going to ask you, so you have already told that you don't have any past surgery. Okay. Can you tell me in that, I'm going to ask you a few personal questions, if you don't mind.
Yeah, okay, go on.
Okay. Who lives with you at your home?
I live with my husband.
Okay. And can you tell me in that, is there any problem while climbing the stairs?
No.
Okay. What's your occupation?
I'm a teacher.
Okay. All right. And can you tell me that, do you smoke?
No.
Okay. Do you drink alcohol?
Yeah, occasionally I drink.
Okay. Okay. How many pence?
I take a can of beer
Okay. All
every
right.
3 days.
And all right. Okay. And so what do you think the cause of your this discomfort is?
I'm not really sure, doctor. I have,
Okay.
it really worries me. I'm just worried like it may be something serious to do with my heart or something.
Okay, can you
Okay. And
summarize your history now, please?
okay. My patient is 36 years old, Alice. She comes with the complaint of shortness of breath that started gradually a few months ago. The shortness of breath is intermittent. The patient said that this problem increased when she's stressed out, and it's gone when she's calmed down and relaxed. So there's no manifestation of pulmonary embolism, as there was no chest pain, no cough, no leg swollen, or the surgical history. And the patient doesn't have any chest infection, no manifestation of any bronchogenic carcinoma, or no manifestation of any anginal pain. So, but
So
the
what are your
patient,
differential diagnosis?
yeah. So based on that, my main differential will be anxiety that is related to the operation, which is going to be held for this patient. But I can also consider the myocardial infarction, the pulmonary embolism, any chest infection, any bronchial asthma, any bronchogenic carcinoma.
Yes. Okay. Right. How
Yeah.
would you confirm your diagnosis?
So first, I will, as the patient said that she was being, she had all the investigations before for the chest pain. So I will contact the patient's GP and will try to collect all those reports by myself.
Yes.
And I will do the patient's examination by myself. I will repeat the patient's bloods, and I will repeat the patient's chest X-ray, ECG, and the arterial blood gases.
Yes.
And I will make sure that the patient had a recent echo done and also the angiogram. And if I get that, I will discuss it with a cardiologist, and I will reassure the patient. That she's going to be fine, and whatever we can do to allay her fears, we can do that, and we'll try to involve the patient's family and friends so that she can have a good support before and after the surgery.
Good. According to your opinion, do you think the patient can go ahead with her planned surgery?
Yes, because we don't have any evidence, as in the history,
Yes.
there's no evidence of any cardio or pulmonary disease. So yeah, the operation should go ahead.
Good. Right. Yes. Can you first give feedback?
Thank you, Dr. Benish.
Thank
you sounded confident.
Yes.
You covered most of the things.
Yes.
And maybe if you're a little fast, you could have finished everything.
Yes.
Yes.
One or two comments, like it's a small comment, a small
Yes.
thing only. Like you initially you asked how can I help you today? Then only you asked, like, you didn't gain the permission first. You should
Okay.
begin with, like, I would like to
Okay.
ask you a few questions about your condition. Is that okay with you? Then only when patient says, okay, you gain permission, then only you ask what brings you here or how can I help you?
Okay. Yeah.
Then in the second thing, like, you already asked me the family history, then only you jump to saying that I would like to ask you some personal questions. So you asked that
Okay.
first, and then maybe after that you begin with the family history, personal history, and all these things. And you did cover all the presenting complaints, and also you ruled out all the differential diagnosis. Did you mention specific time of the day? I mean, you feel
Oh yeah,
this,
I missed that.
You
I
forgot,
missed that.
yeah.
Yeah, I forgot that.
and also, like, are you breathless only when you're anxious? That-
All right.
Yes. That
Yes.
also she forgot to rule out anxiety.
Yeah, exactly. Yes.
Yeah. So rest of the things, I think you did pretty well.
Good.
So,
Thank you.
Thank you.
Yes.
Thank you.
According to me, I request this, since it was your first time. So if you don't get to complete your history, then the moment examiner asks you, can you summarize your history now? So you begin with, okay, if time would have allowed me, I would have completed, because
Okay.
expectation you asked, concerns, and idea you asked, so expectation and concerns you had to complete, and then systemic review. So
Yes.
you first should do that, and then you should summarize in 30 seconds. And for me, I think your summary that you summarization of your history 30 seconds, that needs to be improved.
Okay.
Because you told in first sentence, you told me very nicely, and then when you went on and told me there was no manifestation of pulmonary embolism, no, you're not going to look at the implementations. You have to rule out, okay, there was no chest pain, there was no everything that you were, there was no underlying anxiety or whatever, like the differential diagnosis that you were trying to rule out. So you have to mention the symptoms or the condition, the complaint of the patient, because this is history, patient is telling you it's complaints. So you have to say these were the things which were not there. So then you have to mention, okay, what were the positive findings, if there was anything in particular in the history, like in the family history, or if there was any past important history, so that you have to mention.
Yes,
Good. So work on your presentation of 30 seconds.
Yes, ma'am.
For next time. Good.
Okay.
Thank you.
Yes. Thank you, ma'am.
Question, please. Right, so if you have read and understood, considering the communication skills station, kindly begin.
I'll make some noise. I'll enter the room. Hello, my name is Fozia. I'm one of the doctors here. Can I confirm your name and date of birth?
Well, I'm John and I'm 52-year-old.
Nice to meet you, John, and thanks for confirming. Today, I have been asked to ask you some questions regarding a medicine that you've been taking. Is that fine?
Yes, doctor.
Could you tell me more about the medicine you are taking?
Well, doctor, I'm taking this medicine called warfarin, and my doctor told me that I shall not stop this medicine because it's important for my health. Otherwise, I can even die. I had an operation. So since then, I'm taking this medication.
I can understand your concerns, and let me tell you a bit about the medicine. The pill you are taking is a blood thinner. It works by thinning the blood. As you have underwent a surgery previously, you have been advised to take the medicine to keep your blood thin. But as we are planning to operate you, we need to stop your the blood thinning for the time we will operate you, because it will lead to bleeding. So we will stop the warfarin 5 days before the surgery. For that, we need to stop it 5 days before the surgery, and for that time, we will cover with some other drug, and we will admit you 5 days before the surgery. We will stop warfarin and start you on another medicine, heparin. That will cover the time during which the warfarin will be stopped. And we will stop the heparin the day before the surgery, and then we will operate you. Did you understand so far?
Yes, doctor, but why you want to stop my warfarin? Because my doctor, as I told you, like he told me that I shall never stop this medication.
I can understand.
And I don't want to stop it.
I can understand your concern and apprehension in stopping the medicine. As as I already told you, I will shift you to some other medicine. The problem with warfarin is that even if we stop it, its effects in the body will be for 5 days. So we have to stop it 5 days before the surgery, and for that time, we will give you heparin injections that will keep your blood thin during the time.
Well,
And
doctor, I am not comfortable with injections. I can't take for long, like at home, I can't inject myself. You can see my condition.
I understand that, but we are going to admit you 5 days before the surgery. We will stop your pills. We will give you injections here. And the day before the surgery, we will stop heparin and you will get operated. After that, we will start heparin and warfarin injection and warfarin pills also.
So I have to take a warfarin and heparin after injection, after my operation. The both are at the same time.
Basically, we will initially start with heparin, but as soon as we are sure that there are no chances of bleeding, and we can start heparin. Then, when you are orally allowed, we will start with warfarin. For some time, we will continue both heparin and warfarin, and after that, we will do some blood test, and when the blood test shows that the warfarin is acting sufficiently, then we will stop heparin and you will be taking only warfarin pills.
Okay, so how long I have to stay in hospital? Because I don't like being in the hospital for long.
I can understand that staying in hospital is really feels really bad, but you will need to stay 5 days before the surgery, the day of surgery, and some days after during the time we will again get your warfarin in the range for a few more days after the surgery. But
Okay.
if there is someone at home or some medical facility which is or district hospital near to you, we can help you to get injections from there during the pre-op before the time you are getting operated. But I think it will be convenient for you to stay at the hospital and get the injections here. So we will have a better look at your test too.
Okay, doctor, I am taking some anti-anxiety pills as well. Like I can't sleep at night. So should I have to stop them as well?
No, you can have them as usual. And on the day of surgery too, you can have the same pill and with a small sip of water in early morning.
Okay.
Okay, so let me summarize for you. Is there any part or anything that you didn't get or you want me to explain again?
No, doctor.
So let me summarize for you. Your doctor has put you on blood thinning pills. Before we will admit you 5 days before the surgery. We will stop those pills, start you on some injection to cover for the effect of the pills. And on the day of surgery, we will do a blood test. And after that, we will stop the injection before day of the surgery. And after you get operated, we will start the heparin. Then we will start heparin along with warfarin for pills for some time. When your results is when the warfarin takes its action, then we will stop heparin and you will be discharged home on warfarin pills.
Okay, sounds perfect.
Thank you. Do you need any assistance with the door or any help with finding the way out?
No, I'm fine.
Well, thank you. Thank you so much.
Okay, you still have 1 minute. Anything else you want to add? All right, can you start giving feedback to Mamuna?
Ma'am, she was throughout in the conversation she was involved and she was answer all the question. Yes. I had a little bit problem in the beginning, like she asked name and the age, and she can only confirm like by repeating the name of the patient, like are you Mr. John or something, who are looking for me to talk about some medication, something like that. She can start like that.
Okay.
And secondly, she should also mention some test, like to explain, like we have to do some blood investigations after your operation, and then when those reports come, we will stop heparin and we will continue the home medication with warfarin, something like that.
Okay.
Yeah, otherwise like she was quite explained everything.
Yes. All right, good, thank you. Yes, anyone else want to give feedback? Okay, who would tell me in this scenario, patient is blind or actor is blind and would be wearing sunglasses or dark glasses. In this scenario, when you approach the patient or when you have read the scenario and you bell goes and you enter the room, how are you supposed to approach the patient? Because patient, you know, but why you have to see the patient. So how or what should be the opening question or the first question with which you will come across with the patient? Who would tell or who wants to comment?
Ma'am, I could go.
Yes, please.
When she entered, she said that she'll knock. So that is one way that she's alerting the patient that there's somebody else who is entering. So that is one. Another is perhaps shake hands with the patient. I'm sorry,
No, it's
put a
post-COVID.
hand.
Yes.
Okay, post-COVID, yeah.
Post-COVID.
Yeah,
no
post-COVID,
shaking,
so no
physical
shaking
contact.
hands. Yeah. So in that case,
What would be
she
your
can.
opening sentence? What is the most likely or the possible opening sentence? Because here the question is you have to consult. Yes.
You have to
console this patient. Why?
Yes.
Because patient is maybe conscious or
anxious about taking the medication. Yeah. So in that case, I think what she did was because the patient is unable to see, so she knocked. She gave a visual. She gave an audio alert.
Yes.
So that was something okay. And after that, she did introduce herself. So
okay.
So that way.
My question is, what should be the appropriate opening question?
How are you feeling today? Or
all right, okay. Person is male, he would always say, I'm absolutely good, always good. So maybe you can say, okay, I'm here to discuss with you since
I can't talk to you regarding medication. Yeah, like
you
that.
were a little concerned about stopping that particular medication.
Yeah, initially try to calm the patient down. Like
gain
say
the trust.
That
yes.
Yeah, I'm your consultant has asked me to speak to you regarding this. I hope you will can I have some time from you so that I can speak? Are you ready to listen? Something like that will allay his worry.
Yes, and you can just say, okay, I apprehend your concern. So you are reassuring to the patient or gaining trust of the patient.
Yes.
So these are very important.
Yes, ma'am.
Beginning, yes, how you begin, how you greet or come in contact with the patient. The first sentence that you say. Good. Yes, and here is the question. Right. If you have read and understood, considering this communication skill station, kindly begin.
Hello, I'm Dr. Muhammad, one of the surgical doctors. Yeah, confirm your name, please.
I am Mrs. Wilson.
Mrs. Wilson.
I'm actually, doctor, I'm worried about my son, John. Where is he?
Nice to meet you. Can you have a seat, please?
Yeah, sure.
Okay, this is tissue for you.
Thank you.
Firstly, I'm Dr. Muhammad, one of the surgical doctor. I'm sorry we haven't contacted you earlier, but you have to know that your child has been in the fall down, and he's in the theater emergency. Unfortunately, we couldn't wait until you arrive because this is urgent condition. Before we start, I will tell you everything about your child condition. First, I would just want you to know how far did you know about what happened.
But doctor, my son was doing well. I went to work. He was with his father. All I know that he fell from the swings in the school, and now he's going to have an operation done on him. I don't know what's going on. Please, I'm really worried about my son.
I'm sorry to hear that. I'm sorry to hear that, really. His father told us that he was playing in the school and he fell down from the swing. So he called an ambulance. I'm really so sorry.
That's okay, Dr. Mohammed.
It's okay. It's a child problem.
Yes. Small children.
It's all right.
Sorry. His father told us he was playing in the school. He fell out while he was swinging and he felt out pain. So he was called the ambulance. And he's
Is
now
it something
in the
serious, doctor?
Unfortunately, we did the scan and we found that he has ruptured spleen, which is called spleen. This is an organ in the tummy, in the left side, upper side of his tummy. Unfortunately, this is critical conditions and it is emergency. So that's why he has been taken to the theater urgently. But don't worry, he's in good hands and experienced surgeons. But you have also to know that he might affect his own life.
But how? He was all well in the morning today, and now this. And actually, I don't know. His father and we aren't together, and his father has this drinking problem. So I have this worry all the time whenever my son is with him.
I'm really sorry to hear that. I understand your situation. I also have to share this with you as in your conditions. We have to take extra precautions, okay? I will have to make some standard procedures just to make sure your child is in good condition at home. And also I will involve child protection consultant and child protection service just to make sure your child is good. And also we have to make sure everything we do, it will be in his best interest.
Thank you, doctor. The spleen organ that you're saying, what is it? Is it very important?
Spleen, this is organ in the tummy. It's in the upper left side of your tummy. This is important. It has some immune functions. It's protect against infections.
So what are you going to do? Y'all can keep it, right? I mean, the operation.
Unfortunately, we have to remove it if it is necessary to.
So then won't that harm my child?
No, we can remove it, but we will also have to give some vaccine to protect him against infections. And also he will have to take lifelong antibiotics.
Okay, doctor. If you must absolutely do the operation, then I think go ahead, but I'm really worried.
I understand your situations, but this is emergency situation. Your child in good and experienced hands. We will do everything we could. Okay.
Okay, when can I see him?
Okay, but when can I see him?
You can see him as soon as he went out from the theater. Okay.
Okay, and after that, are you going to do something? Or he has to stay for long? Does he have to stay long in the hospital?
we have to make sure that our priority is your medical child care. Okay. We have to make sure that he is in good recovery, and also we have to take full examination after the operations. And you can go home after, make sure that he is in good conditions.
Okay. Thank you, doctor. Thank you for explaining me this.
Okay, before we end up, I would like to just summarize what we have been through. Okay, your child has been fell down while he was swinging in the school. He has something which is called ruptured spleen, and he might have to be removed. Also, he might have to take long time antibiotics. And you can see him as soon as he went out from the operations. Okay, if you have any questions, don't hesitate to contact me. I will leave my number with Zeynep. Thank you for your understanding.
Good. Thank you, doctor.
Few seconds. 35 seconds are left. Yes. So if you can start giving the feedback.
First of all, Dr. Mohammed, you have to be a bit sympathetic towards the mother, more sympathetic, and don't say you understand. That is right, Dr. Abbas said not to say you understand, because actually as a doctor we'll never understand how the patient as a mother is feeling at that time. So just, yeah, like he said, sorry to hear, sorry, I understand, sorry for your state right now. I'm feeling very sorry. Say something like that. And and about the child's thingy, when the father's thinking, you don't know about this, none of your consultants know. So this is a brand new information for you. So you go like, oh, okay, fine. I'm going to have to inform my consultant about it. I'm going to involve inform the child protection services, and we are going to ensure that next time, something like this does not repeat. You have to be more, sympathetic and more explanatory to the patient.
It will come with time.
Yeah. Yeah, it will come with practice. Yeah. Otherwise, you covered everything. So yeah, it's good.
Thank you.
Thank you so much.
Thank you, ma'am. Thank you.